I was going to talk on Friday, and then when Dr. Fuqua could not talk tonight, we thought, well, let's make Friday a little bit shorter. And since everybody's already blocked off this time, take advantage of this time to talk about some communication strategies. And we've done some other communication strategies earlier. We talked, you may remember at the very beginning, talking about giving feedback. Kind of remember that? And you've been using it, right? And I heard some of that last week, some feedback. I think I heard more feedback coming from faculty than from trainees, but some feedback to your presenters on the rare condition presentations, which were excellent, by the way. I mean, that's not useful feedback. It's just kind of complimentary feedback, but they were really, really good. And I think, I hope that it gives you a little bit of a background on when you run into another rare condition on, kind of how to look things up and where to find things and what you might want to know about it. Before we launch into communication strategies, I just want to mention something about Module 9, which was a long time ago. It was last year. We had Module 9. There is a reflective statement about the TED Talk that you watch, and half of you have done it and half of you haven't posted yet. So those of you that it might have slipped your mind because it was so long ago. But if you haven't done the reflective, just you watch the TED Talk by Maysoon, who's a comedian with cerebral palsy. You watch the TED Talk and then a brief reflective statement. So if you could go ahead, those of you that haven't, please do that in the near future so that I can check it off my calendar, because I read them all. I like to read them all. Okay, so I'm going to move into talking about some communication strategies. And first thing I want to do is acknowledge that all of you are skilled communicators. You wouldn't be LEND trainees. It's a highly competitive program, and you gotta want to communicate to be part of this program, and you're all people that are good at communicating. And so as we talk about communication strategies, I do not want to make any implications that you need remedial work on communication. These are some strategies that can perhaps help you enhance your communication skills, and particularly in challenging situations. My background on this is that I learned a number of these communication strategies as a faculty member at College of Human Medicine at Michigan State. We have communication courses, they call them interactional skills, for first and second year medical students. And I found that by teaching those and breaking down a lot of the things that we all do every day, but breaking them down into smaller steps and acknowledging some of the smaller steps and then practicing certain steps of communication really helps our students be better communicators, and certainly helped me become more skilled at communication. Not to say that I don't put my foot in my mouth sometimes, and I not always clear, but that it really, I have learned a lot. Now, the course that I've drawn from is an 8-week course, 2 hours a week in small group. And we're going to cover that and more tonight in the next 60 to 70 minutes. Okay. So this is going to be a whirlwind, but I hope you'll get a few cues, some things that you might want to take home and work on. Okay, we got it there. So this is just the intro. So here's what we'll be covering. The learning objectives, a little bit on basic skills. I think you've got these in the bag, but we'll cover a little briefly about how to establish rapport in clinical and educational encounters, how to lead a team conference. You're likely to be called on to lead meetings or conferences, and a big focus on addressing emotions. More advanced skills, we'll talk about some skills for effective communication when there are different points of view, and how to establish and build rapport in challenging interactions. And then I've also want to talk a little bit about inclusive communication, and this is principles of inclusive communication with a health equity lens. learning some preferred terms on some resources, and maybe and if we have time, to have a little bit of a conversation about this. There's always an evolution of terminology, and that is certainly true in the world of disability, and it's very much true in the world of diversity and inclusiveness. And it behooves us to be aware of changes in vocabulary. So let me just begin this, before an encounter, if you have a chance to do this, an encounter like a clinical encounter for me, before I walk into the room to see a child and their parent, or if you're pulling together a conference meeting or an IEP or a meeting with people, it really helps to know the facts as much as possible, know who the players are, know what the concerns are, avoid making assumptions. You want to have the background, have the context, but you don't want that to lead you to making assumptions, and you do not want it to lead you to making a judgment, be prejudged before you go in. I think you all know this. In reality, in my world, in pediatrics, I frequently don't have time to know the facts very well. I'm often going into a room without knowing very much. I try to take a few minutes to look at the medical record. It's a great advantage if I already know the family and I know the child and I know what the issues are, but sometimes I'm just going in blind. Try to do a little bit of homework if at all possible. To tell you the truth, though, even with that, it's kind of frustrating because in some of the clinics I work, there's a lot of fluidity on who comes in, and I might spend time going over the whole chart. And of the people that are on the list at the beginning of the session, about half of them actually come in, and the other clinical appointments are filled in by people that come in at the last minute because people's schedules change. So, but do as much as you can to have some background, have some information, and you'll see how this plays out when we do our role play at the end. Again, this is stuff that listen more than talk. Ask, talk a little, ask. Use open-ended questions. Sometimes it's hard to formulate an open-ended question. It's so much easier to ask a yes-no question. I find that I use the phrase, tell me more about, very, very frequently. I'd like to know more about. Can you tell me more? Tell me more, rather than sometimes, because again, sometimes it's hard for me to think of a nice open-ended question, and rather than something that gives me a yes-no answer. And something I'd like you to practice is how to interrupt people, how to redirect and interrupt. And you don't want to do it too much. I know there's a classic study that was published probably 35, 40 years ago. Somebody watched physicians in offices and found that the average time from saying hello or asking a question of the patient, the average time interval between asking the question and interrupting was it was either 18 seconds or 19 seconds. It was pretty clear that they weren't listening. That's not what I'm talking about here. What I am talking about is if the conversation is going in tangents, or you're running out of time, or you just need to get back on track. Learn some phrases to help you interrupt. Phrases that I use often are, I'd like to get back to. You said something important, let's return to. That's a way of kind of making it a positive about face to get back on track. And there's a balance here, because sometimes those tangents are important, or letting people just tell their story can be really important. And you can get it builds rapport, and not only builds rapport, but there may be information that you won't get by a more directed interview. However, you have to balance that with, we usually have time constraints. You can't just stay there forever. You've got other clients to see, and the person you're talking to has other things to do. So again, practice using some terms, some phrases, come up with what is comfortable for you to redirect and interrupt. Now I want to talk to you a little bit about addressing emotions. And this is something that here at the medical school here, and I think in communications courses in medical schools across the country and around the world, have learned how important it is to help our trainees and our professionals learn to address emotions. We're not very good at this. We have feelings, we know about feelings, we maybe can talk about feelings with friends and family, but we often shy away from talking about feelings in our clinical encounters. And it's been shown that connecting on feelings really helps to build rapport. And you don't have to spend an awful lot of time on it, and you don't have to get all touchy-feely and overdo it, but just addressing emotions can be very, very helpful. And there are different ways of framing this. One framework that has been developed by a colleague here at Michigan State is he uses this acronym, the NURSE: name, understand, respect, and support. Others will just be, more abbreviated: name that emotion, show your respect to the emotion. Now, showing respect to the emotion doesn't mean that you necessarily have the same feeling or agree or think it was the right response, but it is the person's feelings, and you can respect the fact that that is indeed their feeling and acknowledge it. So one of the keys here, and we'll practice a little bit with a couple of scenarios, is just naming the feeling, understanding the feeling, respecting and supporting it. In terms of naming, sometimes people say it's better to ask the person, how are you feeling? What are you feeling? Others prefer you name the feeling and then they can contradict you. What comes and feels comfortable. Sometimes people don't respond too well to, so how do you feel about that? It feels a little canned. If you can say it with sincerity, it works. You got to figure out what works for you, but something, get out there, get a name. We can deal with feelings better with the whole world. We deal with, human beings use language, not necessarily verbal language, not necessarily words, but we do use language and communication to help us navigate our world and understand our world. And that is true with feelings too. Something else that I think you'll find can be very helpful is the use of hope statements. I hope we can. We all hope. A simple hope statement provides a positive frame and shows alignment with the goal. So just throwing in a hope statement and just remembering to use a hope statement, it can help, particularly if you're not totally aligned and you've learned a little bit. You've had some things in this current module about sometimes of evidence-based treatments, and some of the discussion is, what if a family or a client or a patient wants a treatment that's not evidence-based? How do you deal with that? Well, one of the ways you can help with the communication is show alignment through a hope statement. So conversation grenades, these are comments that you just catch you off guard and you just want to run and hide under the table. And I think you can imagine some of these where it's just they're emotionally laden and you're uncomfortable. And what we usually do is change the topic. And that may be an effective way of doing it in social encounters, or, at a party, if somebody says something that just says, whoa, change the topic. But in clinical or educational encounters, pretending it didn't happen is generally not the best strategy. So examples of conversations with grenades, this may sound familiar to you. You've given up on my child. This you might hear in a medical or a therapeutic setting, or it may be in an educational setting. You've just given up on my child. You're proposing that educational plan. You want to put him in that classroom because you have given up on him. Another that can make people very uncomfortable is, I'm praying for a miracle. And you don't have a miracle in your toolbox to offer. Or if somebody says, it's all my fault. I know, it's all my fault. What do you do with that? How do you respond to that? Or no one understands what we live with. Again, these are kind of comments that frequently just sort of move on. Well, it helps to address it. So don't ignore the statement, don't ignore it, but also don't make assumptions. But it's so highly charged. Some of these comments are so highly charged that I or you may make an assumption that is not really what they meant. So ask about it. Tell me what you mean. I wonder what that means to you. You've given up on my child. Tell me what that, tell me more. Tell me what you mean. So don't assume the meaning. So I wanted to use a little example here. I'm praying for a miracle. Somebody says that. So response is, so what does that mean to you? What would a miracle look like? So answers could be, my child will be like other children. This is, say the context here is a 6-year-old with a diagnosis of autism. He'll grow up and get a job and get married and have children. Could be as simple as he'll use the toilet for pee and poop. You don't know what this family's miracle is. Let's say it's the last one. So to use that, addressing the feelings there, again, you could launch into, well, here's what we can do to help him learn to be toilet trained. But first step would be to address the feelings. Sounds like you're really frustrated that he's still in diapers. Quick acknowledgement of the feelings. Must be exhausting, kind of disgusting. Any parent would like to have a child, their child toilet trained by this age. And then the support, I'll work with you to help him learn to use the toilet. And I think you can see that frequently we would just respond by, okay, well, let's work on that. If you can step back and address the emotion first, that will help build rapport, which will help you then move forward and tackle the issues. And if you wanted to add a hope statement, we all hope he makes progress soon and you don't ever have to change a diaper again. Another example. Mother of a child with autism comments, my in-laws say things that suggest his autism is my fault. Comments about what I did when I was pregnant and how I didn't discipline him when he was younger, things like that. So any volunteers on how to do the nurse? What name would you put on that feeling? Alasia.
I would say guilt in a way. They probably feel guilty,
Yeah,
even though
and
it's not necessarily their fault. It's not, I'm not going to say necessary. It's not their fault, but they feel guilty because there's somebody shaming them for the way their child is. So, oftentimes, so yeah, I think they would be feeling guilt.
Yeah, and then how would you say that to the, how would you express that to the person?
Okay. So that's the hard part for me. I would try to validate their feelings, because like, well, I understand your feelings. Then I would try to reassure them that it's not their fault, but
Okay.
I understand the feelings that they have.
Yeah.
I'm not sure if that's right.
Well, I mean, one way you might say it to name the feeling, it sounds like you're feeling guilty, even though you know, and I know that it's not your fault, but you're
Right.
feeling guilty.
Mm-hmm.
What other feeling might this mother be having besides guilt? Her in-laws are telling her this stuff. Jason.
General feelings of inadequacy, like she's not a good enough mother. She was like,
Yeah.
they said all these things about how she didn't discipline well enough and stuff like that. I guess in terms of addressing that, it'd be worse thing. When you hear that consistently, you eventually begin to believe that maybe you're not doing a good enough job as a mother, and that's hard to accept when at the same time you're feeling like you're also putting forth every bit of energy you have into taking care of your child because you do love them. And I really liked what you said, Jane. When it came to the guilty thing, as you said, uh, you recognize that she didn't need to feel guilty. And I think a lot of times in these conversations, people need to hear that not only be validated, but believed also and understood that they are trying their best when other people aren't necessarily looking or thinking that way.
Yeah. Yeah, and something in this conversation. So we've already talked about the guilt and the understanding of it. another feeling she might have, and this is kind of hard to tell without hearing her tone of voice, she might be feeling angry also or resentful.
Mhm.
And so, I don't know that, just from that little sentence I gave you, don't know that, but that might be something that you feeling guilty because of what you're hearing. And as Jason said, because you keep hearing these things over and over, you start to believe them. But also, I wonder if you feel resentful for your in-laws because you're doing all the work and they're blaming you. I can understand how that might be pretty hurtful and difficult. And I have a tremendous respect for what you've been doing with your child, and I hope you do understand. I believe you understand that it's not your fault, and then support. So let's get to work, and let's continue with the work that we're doing and that you're doing to help him gain new skills. I'm just kind of, blabbering on about this, but sort of just this addressing the feelings she's having. And some of the feelings may be not obvious. And then the other is that, the person may say, well, it just makes me so upset. I just can't even sleep at night when they say, more may come out or may not, may be able to move on.
Jane Maya posted in the chat that.
Oh, I'm sorry, I can't
Oh,
see
that's
it.
okay.
Yeah.
Yep. She might feel isolated. These are family members telling her this, and family members are usually supposed to help support your children.
Good point. Very good point, Maya. Yeah, she may, and that may be another feeling. You're feeling isolated, and perhaps you're even isolated and feeling lonely, and just addressing them and naming them and helping her name them, because she may have just a whole swirl of feelings that it's hard to name them.
And Julie also posted, she said she may feel judged and feel the need to defend herself, which may shape how she expresses herself during the encounter.
Oh, that's a very good point. Feeling judged and may become, how does she express herself and to defend herself, and she may come across defensive with the professional, and it could get in the way, and it helps to acknowledge that. All right, I'm going to go to another one. This is a little more challenging, and this is a real life and in a scenario that one of my colleagues in pediatrics faced not too long ago. And we'll do a brief role play with it. Doing okay, I'm just checking my clock. So this is a 6-year-old was brought into the clinic by his mother to her primary care pediatric clinic because of escalating difficult behaviors. He's had violent outbursts at school. He's more withdrawn at home. He has angry interactions with his siblings, and he's having more trouble falling asleep. This is a complicated little boy. He has the diagnosis of fetal alcohol spectrum disorder. And you've learned a little bit about that, how that can affect behaviors and executive function. He has been diagnosed with ADHD, which is true of so many kids with fetal alcohol spectrum disorders, and oppositional defiant disorder, which doesn't help us too much, except to know that he can be a very challenging, has a negative affect and is also challenging. He's taking a stimulant medication for his ADHD and an atypical antipsychotic to stabilize his moods. He's taking something called Abilify. His mother is upset because his usual pediatrician, who knows him very well, is not available today, and the doctor in clinic has never met him or her before and has never taken care of him before. So this is a challenging situation. She made the appointment anyway because the behaviors are so out of control that she wants to get something done, even though his regular doctor is not in today or this week. A little more background, a little more of the context. The Abilify he's taking, the atypical antipsychotic, has been prescribed off-label. That means it has not been approved by the FDA for use in children. Now, this is common for many medications, particularly psychiatric medications, psychotropic medications. This is very common that pediatric psychiatrists and pediatricians use them when they have not been studied in children. So many have not been studied in children that, you know, we're really limited in what is available. And so instead we use guidelines that have been developed by experts. Drugs have been approved in adults. They have not been found to be dangerous in kids, but they haven't been studied in kids. And you can imagine one of the reasons for this is just much more difficult to do studies in kids because of all the issues of informed consent. The doctor in clinic today who is seeing this child doesn't have much experience with this particular medication. She does know that the doses he's on are already at pretty much the upper limit of the guidelines that have been developed by experts. The child's mother is really upset. She's really upset she couldn't schedule with the child's regular doctor who knows her child well and who knows about the medication. And she's really worried that nothing is going to happen because she got the wrong doctor today. So the mother asks the doctor to please increase the dose of the medication. This medicine works. It helped when we started it, but he's no longer responding to this dose. Please go up on the dose. And the doctor is uncomfortable because she's unfamiliar with it and it's already up at the top of doses. Pretty good scenario, right? And I'll tell you, when it happened in the real world, it didn't play out very well. Reports, you know, complaints were filed by the parent against the doctor that she didn't listen, she was unwilling to be helpful, et cetera, et cetera. So let's see if we can play it out so that it works a little better. And I got 2 volunteers, one person to be the mother and the other to be the doctor. I'll stop sharing for a minute while we do the play. We'll just take 3 minutes on it, just a couple minutes. Oh, I don't want to have to pick on somebody.
I can be the doctor.
Okay, Alasia, that's a lot. That's courageous of you. That's great.
I can be the mother.
Great, wonderful. Okay, go for it.
So, hi, please, I need help. My son giving me a very hard time. I'm giving him the medication. It's not helping at all, and he's not sleeping. And I need like to do something. I need to give me like higher dose of the medication.
Hi, so I hear your concerns about your son and the need to up his
You
dosage.
don't understand. You don't understand. No, you don't hear me. You don't understand. The situation is really bad. You're not in my house. You don't know what's going on. I cannot sleep, and the teacher at the school, they cannot take him out. No, you don't understand.
I know the dosage he's on currently is very high, and since I'm not that familiar of working with him and
But I need
his
help.
current doctor, I'm not that
I need
comfortable
help. You're not
with the
helping
dosage.
me.
I'm sorry. I'm just trying to like.
I'm the weirdest parent ever. That's what they're gonna come to.
Yeah. I hear your concerns, and I really do want to help. But since I'm not familiar and the dosage he's on already is pretty high, I don't want to take the risk of upping it and it causes harm to him, since I'm not familiar on what works best for him as well. I don't know.
This is my fault that you don't know. You're not familiar with the medication. I need help with my child. I need to find me a way. I need you to increase his medication. This is not my fault as you're unfamiliar or the other doctor is not here today. I cannot deal with the situation anymore. You don't understand what I'm going through.
Well, I can see if I can try to reach out to him or the doctor. I can see if I can try to reach out to the doctor and see if they can, if I can talk with them and see if they approve of this decision before I don't want to just up the dosage without speaking with their primary pediatrician, because since they know them better than I do, I feel like it would be best for me to speak with them before I up the dosage.
And when I can have the answer, when can I have like my son's like dose increase? I need that as soon as possible.
I will do my best to I will contact them right now if you want me to. I will contact them right
Okay,
now.
thank you.
Get an answer.
I appreciate that. Thank you so much.
Very good, very good, very good. Anyone have any comments, any feedback on our actors here?
I'm sorry, but
No, great.
I'm so sorry, but I know the situation when the mother like very upset and they don't let even the doctor talk. I know that.
No, you played that beautifully and very realistically. I don't know how many of you have been in that kind of situation. I think both of you played it very realistically and very well. Alasia, you tried to solve the problem.
Mm-hmm.
You tried very much to solve the problem, and there is this, could the doc call the other doc, and you came up with a solution. Let me talk to the other doctor and get back to you. Aaron, you have something you wanted to say.
Yeah. Can you guys hear me?
Yes.
Yes.
Okay. Yeah, I was just gonna ask, because like I'm not on the medical side of things, but I've also very much been the patient saying like there's something wrong, just give me an answer like right now kind of thing. Is it possible to call the doctor if they're not like, do you guys have like pagers for emergencies, something like that?
Yeah, it is possible. I mean, it depends on the circumstances. I don't know why this doctor wasn't in clinic. Is he sick today? Is he out of town? Is he, teaching a class? He's probably not available at the moment, but he may well be available later. I'm looking at, let me read what Grace wrote. I think did a great job fleshing. Yeah. No, I did. So let me back up though and say something that it might have been helpful. Raina, you did a tremendous job of being that frustrated, angry, help me now. You expressed it beautifully. Alasia, you might have been able to bring the temperature in the room down a little bit if you had addressed the emotions before trying to find a solution. Just I hear you're really upset, and I hear that you're really worried about your son. I do hear you, and I don't know what it's like because I don't live at your house, but let's see if we can come up with a plan. And then the other is that I sometimes will apologize to people and say, I'm really sorry, you were hoping to see Dr. So-and-so. I'll say that I know you were planning to see Dr. So-and-so, who really knows you and your child. You're at a disadvantage today because you got me instead. And I'm at a disadvantage because I don't know your child, so it's harder for me to help you. Let's see what we can do. But the first step is to just address the emotion. And if you say frustrated, you sound really frustrated. She may come back at you and say, frustrated? That doesn't begin to, for one thing, she's not sleeping. I think this is a very good point, Rachel, that you have to be careful about saying words I understand, unless we really can. A better way, it might be saying, I hear you. I hear you. And even to say, I don't walk in your shoes. I can't really understand, but I feel I'm feeling, I'm trying. Yeah.
Lauren had her hand up.
Okay. Oh yeah, Lauren. Good.
Yeah. Can everyone hear me? Sorry.
Yes. Yes.
Okay. So I think that another thing that I've found helpful when I've seen doctors do it is they basically align themselves with the patient either before they start to get upset, but this patient kind of was upset from the beginning. So after they get upset, saying like that you're like say that you're both trying to do what's best for the child, and like just put yourself in and say those words, be like, I want what's best for your child just as like the same as you, we have the same goal. And so then trying to tailor the response out, because I think that they're frustrated because they want what's best and they think that you're not hearing them and doing what's best, but you are. And just saying that the medication isn't, you know, potentially not safe, they might not, like, obviously that's what's best, but they're so frustrated in that moment, they might not think that you're listening to them. So aligning yourself in that way by just saying those words very bluntly can be helpful too.
Yeah, very good point. Yeah, acknowledging that I know you want what's best for your child, and I also want what's best for your child. And in this case, to say my concern, it's not that I don't want to write a prescription for your child. I just don't, I want to make sure that it's safe. I want his safety is paramount. And then move into, as Elijah did, into problem solving, which is, let me get in touch with that doctor. And if the doctor's out of town or something, then the next might be to, you know, gets a consultation, a phone consultation with a child psychiatrist to see what is safe or an alternative, but do some problem solving. But it really helps to, yes, align with the parent and bring down the emotional temperature in the room by addressing the emotions. Because as long as the emotional temperature is so high, it's really hard to have to communicate. I mean, it's even hard to understand, you know, what are the behaviors on the child? What you'd like to know, well, what exactly is happening? Okay, very good. Beautiful, beautiful acting. Let me go back to sharing the screen. So the strategies for success are, as we talked about, know the facts. In this case that we just gave, knowing as much as possible about this child before walking in would be helpful. Know the players, the mother, the kid, the other doctors, the concerns, if you can. Avoid assumptions. Do not judge. I haven't really talked about this, but it's so important that we don't communicate judgment to people. And our clients, whether it's educational or in psychology or in therapies or in all circumstances, are often have been judged and are sensitive to, very sensitive to being judged, and will feel judged if we're not very careful about tone of voice, facial expression. So you just really have to leave your judgment at the door. Then the skills, the strategies for addressing emotions, the naming, and then work on establishing trust. And I want to talk a little bit about establishing trust because it's so important. And you can see in this scenario we just went through, there was no trust. So building trust takes time, it takes experience. Sometimes we have the advantage that people trust us, come in predisposed to trust us because we are professionals. And sometimes people are predisposed to not trust us because we are professionals. Maybe something they've heard or previous experience. If you sense a lack of trust, address it. Just like with those conversation grenades, with a lack of trust, I find it's very helpful to put it out on the table, just to be candid about it. And put it in a non-judgmental way. It's not like, you don't trust me. It's, I don't expect you to trust me. After all, we just met. Let's see if I can earn your trust as we work together. I don't, you know, and use I statements. Doesn't help to blame somebody. It sounds blaming to say, you don't trust me. More to say, I don't expect you to trust me, or I sense that you may not trust everything I have to say. It's my job to earn your trust. I acknowledge that it develops over time. This is hard if it's a one-time deal, but I think for many of you, your relationships with your clients is longitudinal. You get to know them. I think most of our Lynn trainees are in fields where you work with a person over time. And of course, you build trust by beginning by listening to their point of view. So a summary here, good. I was hoping we could, we're not done, but we're not going to go to 7 tonight, which is, I think, a gift of it. We'll have a gift of at least 15 minutes. So in summary, prepare as well as possible, avoid assumptions, address emotions. I can't emphasize that enough. Deal with those conversation grenades, use hope statements, talk about trust. So try to practice some of these skills. Try to practice in your educational or professional or clinical encounters. And you may try to practice the addressing emotions is in some ways the most difficult skill. You might want to try that in even some of your social conversations. You don't want to get too clumsy about it, but you might want to just, it might feel a little clumsy at first. I think you'll find that you're surprised at how people respond. And often people will open up in ways that haven't happened before. So, and the point isn't to get people to tell you all their life stories, but you might find you have a deeper conversation with people if you make a point of addressing emotions. At the beginning, it feels really awkward. It's kind of like when you're first writing that 5-paragraph essay. Remember doing those in middle school or high school? Introduction, blah, blah, blah. It was all very structured. In the beginning, it felt very awkward and structured. And then after you did it 100 times, it sort of flowed and you didn't have to follow the outline exactly. With addressing emotions, it's one of those things that when you start, it feels a little clumsy, but as you get more comfortable and find your own style, you'll find that it gets pretty comfortable. I find that I've internalized it enough that I don't even know that I'm doing it. And I will say that my husband is frequently amazed at how I can sit next to somebody in a waiting room or at an airport, and pretty soon we're having quite a conversation about things that are important to us. And I think that and he's like, oh, where did that come from? And I don't mean that I'm prying or nosy, but just people will talk about things that are important to you when you make that rapport on an emotional level, and you do that through words. Does anybody have any experience with this? I can't see everybody to know if hands are going up. Do any of you find that you're kind of somebody that people open up to?
Kat has.
Kat has her hand
Okay.
up.
Okay, Kat. Yeah, I can't on my screen.
Yeah, people do just kind of randomly open up to me a lot. It's kind of odd. Just people, like I used to work retail, and I had a lady I just came from my husband's funeral and I'm spending her life savings. I'm like, okay. So, and it runs in the family. I see my dad do it all the time. Like, we were traveling in May this last year, and my dad just sat down next to a person in O'Hare and just said hi, and he spilled his whole life story to him. It's really odd to see it happen in the works, I think.
Yeah, makes you wonder what it is about you and your dad that does it. Alasia, you have your hand up.
Oh.
And then we got Lauren and Jason.
I was gonna say yes, because oftentimes I try to listen, because sometimes people just want you to listen. I mean, I know like this is a clinical setting, so you can't just listen. They probably that you have to say something, but like most of the times people, they do open up to me because they know I'll listen to them without judgment or anything. But yeah, but I know that probably doesn't apply to this, since, in a clinical setting, they need an answer like what we just went through. So that was a bit much for me, but it was a learning experience.
Well, you did a nice job with it. I mean, you came up with, you did some good problem solving there, but I think what you said really does apply in clinical settings: listening and non-judgment. That non-judgment is a big part of it. Lauren.
Hi. Yeah, so I think that one thing that if someone really doesn't want to talk to you, or they're not, or they're having issues opening up, then I found that it's helpful to share something about yourself. I think that sometimes that can be counterintuitive because you think that like in a clinical setting, like, you know, whether you're a doctor or other healthcare provider, like it's not about you. But if the patient is having a hard time opening up about themselves, then sometimes and it doesn't have to go super deep, you don't have to tell a long-winded story, but you know, just having them get to know you more, as especially if they don't already know you, if they don't already trust you, or saying like, you know, I feel like the situation you're in might it would make me feel scared. Like I've felt scared before. Like, are you feeling that way or something like that? So that those emotions can come out more. And that like empathy bridge can be gapped.
Yeah. I think that's really important. Often opening up a little bit about yourself, need to be careful that it doesn't then become about you. And I have gone to doctors where most of the encounter is them telling me something about them, and it's kind of like, but it's really helpful for them to open up, for the professional to share a little bit about themselves. Jason.
I was gonna say I'm kind of a lot like Kat's dad in that regard. My wife usually pokes fun at me because I'll sit down and somebody will spill things that I, really didn't expect to hear about them. And my biological dad was very much the same way. But I also spent 13 years working in U of M's inpatient psychiatric unit, and I think that in general just gave me it kind of put me in the mode of having these types of conversations where I'm dealing with parents who are just in this emotional catharsis, and there's chronically some sort of crisis we're having to talk our way out of. So it reminds me a lot of what you said in terms of writing that paper. Is like the more you do it, the more natural it becomes, to the point where in a regular public setting, I might not recognize that I'm doing it. It's just what I've done for so long.
Yeah. I can't tell. Are there any other hands up? Oh, yeah. No, Elijah, is your hand up again, or is it just still up?
Yeah, no, it's up again.
Good.
I also notice like sometimes people, it depends. It could be sometimes like people can sense if you're somebody they can open up to. Like some people, it may not be that they don't want to open up to you because they don't trust doctors at all. Maybe you is something that you're doing or the way you're coming off is off-putting to them. So I don't know if that's like, so sometimes like sometimes we all could rub somebody the wrong way. So it could be something along those lines. So I think it's like sometimes like you even like in my field, we have to like reevaluate how we come off to people in a way. Yeah.
Yeah, we do. We do. And we may come off differently with different people. Yeah.
There's a couple things in the
Okay.
chat, Jane.
Okay, I can't read the chat while I'm
That's okay.
sharing screen.
Julie says she agrees with Malaysia. I find when you sit down and let the patient/parent tell the story with ample space, usually that prompts a full conversation. A problem I am trying to work on is redirecting.
Yeah, that redirecting and getting it and getting the right balance where people have a chance to really tell their story, but also being sensitive to the time and that redirecting.
Yeah. Kat says, my dad is also a hospice nurse, but he got that degree while I was in middle school, and he's always had people who talk to him. I just messaged him about this, and apparently it's the same with both of his sisters and his dad. They call it the NEP ear.
Okay.
Family trait.
Yeah, family trait.
And then
Family
Aaron
trait.
says, I find that disclosing my hearing loss and my use of assistive technology really helps people open up in audiology.
Oh, I bet it does. Any other comments there?
Nope.
Okay. Well, I'm going to now switch gears a little bit. we're going to talk a little bit about inclusive communication. This is not what I've been talking about. This is a new topic, but still in the realm of communication. And I want to talk a little bit about some changes in vocabulary and ways of reframing things to change the narrative a little bit, particularly regarding equity. So we want to use, in just a second, I'll show you some resources. We want language that is accessible and meaningful to the audience, that's respectful and relevant, and this is the big part, to avoid terms that imply negative conditions are inherent to a group. Now, I am not promoting cancel culture or political correctness or be careful every word you say. What I want to talk about a little bit is just some of the thoughts about some language that we use, just as the language regarding disability has changed over time, language that we use without realizing that it may be disrespectful or have some negative impact. Language that I've been using all my life. First, let me go to show you some resources. Are you seeing a resource or not really? Yep, okay. This is the CDC. So I just want you to know that where I'm getting this, it's from the CDC is one of the resources. And then the other is the American Medical Association. And you've got the PowerPoint, you've got the PDF of the PowerPoint if you want to look at these resources later. So this is hard for me, probably harder for me than it is for you, because I have to unlearn some long established patterns of communication. And by virtue of age, I've had these patterns of communication much longer. And I'm not going to unlearn them completely, but I do try to be thoughtful about some of the implications of some of the words. So what are some of the principles? This is a tough one. Avoid adjectives such as vulnerable and high risk. I've been talking about vulnerable families, high risk social situation. When writing a grant proposal, we talk about vulnerable populations, but that labels somebody that there's kind of something weak about them. Avoid dehumanizing language, use person first language. Now we've talked about this a little bit last week. Some people prefer identity first language, but the general rule of thumb is use person first language and ask about it if they prefer identity first language. I guess the main thing is to be thoughtful that some people prefer person first language and some people prefer identity first language, and it's important to know what people are thinking. But when you're talking about a group, it's helpful to use the person first, because you don't know where they stand. Remember, there are many types of subpopulations. This comes from some of the CDC language and AMA, and I think about this as people write grants. You write a grant about Latinos or Hispanics, and like as if there's so many subcultures there. It's not one person, one culture. Avoid words like target, tackle, combat, or other terms with violent connotations when referring to people, groups, or communities. Ring a bell? How often do we use the terms target or tackle, going to combat this? And avoid unintentional blaming. So here's some of the suggestions. Instead of vulnerable groups, talk about groups that have been economically marginalized. Marginalized groups that, rather than having it an adjective describing the community, but more that they have been historically marginalized. Underprivileged, they've experienced disadvantage because, and be more specific. High risk groups placed at additional risk. Again, it's kind of it's not their fault that they're high risk. And this may be splitting hairs, but it begins to build a narrative. This is a high risk, vulnerable population, and somehow it's inherent in the people in the population versus something that has happened to them. High burden, you can talk about disproportionate rates. And here we're talking about person first language. This, you're familiar with this. Rather than, the victims, we use the term survivors. Rather than obese or morbidly obese persons, either people with obesity, naming it as something not inherent in them, but a condition they have. And I mentioned this already. So here are some of the suggestions to avoid minorities, minority, ethnic group, racial group. This is, again, for me, this is hard to unlearn because, and I don't know that I'm going to, but at least I'm hoping that I'll be a little bit more sensitive about it and be thoughtful about what the impact may be on the listener who's hearing it over and over and over. Okay, we often talk about targeting a population. Could say you want to engage with this population or prioritize a certain group, collaborate with or serve. Or when you talk about tackling, think about serving or considering the needs of. You can combat disease or you can eliminate disease. We use a lot of combat and war language. And when we're talking about health, we've had the war against cancer forever, and maybe that's okay. I mean, you want to get rid of cancer, but there might be other less violent terminology that we could use. And again, trying to not to blame people. This is the same resources I showed you before. And then I wanted to open it up a little bit for discussion, for conversation about this. First, are you familiar with this kind of change in the use of language? Is this new? Is this something that you've been learning about? Alasia.
Yes, because that's language, like it's in research a lot, especially like HR research. We use like marginalized minority a lot. So I can see how it's hard, especially when you're used to writing and seeing a bunch of research papers being written in that type of language. So for me, my mentors I have worked with, they kind of helped me with language. So I've kind of slightly transitioned from some of that, but it was hard initially because you're just so used to seeing it being, that's how things are written. And so it's like really hard to like get out of that now, but it's important that like, although we are, that's how things were done in the past, it's important that we know now that there is, we do have to move forward and learn anyway. Yeah.
Aaron, I saw your hand pop up second.
Yeah, this has definitely been a conversation probably since I was in undergrad. As I've moved forward, I found myself to be adjusting well. But it's always a little awkward being somebody within a community, within the hard of hearing community, because everybody has a different experience. And for me, my hearing loss most of the time is not my primary disability. So and I was just talking to somebody about this earlier. It's sometimes I feel like I talk about my disability too nonchalantly. And then what if people take that wrong? And it's like, oh, well, yeah, people with disabilities, they don't really have it that bad. Or, sometimes I wonder if I'm doing justice to the community, I guess, if that makes any sense.
Yeah. And that somehow you have to represent a community.
Yeah, definitely have been the token child here and there throughout my life. So, and that's always awkward because everybody experiences hearing loss differently, just like with anything else.
Yeah. Kat, I think your hand was the next one up, and then Lauren after Kat.
So regarding if we're like taught about a lot of the language shift, when it is brought up in conversation, it's usually amongst me and my peers, not so much like somebody who is like a teaching person in front of us. A lot of the conversations that we bring are prompted by things we see on social media. I know, like, we kind of joked about TikTok and stuff last during the virtual session, but honestly, when it comes to me shifting how I use language, TikTok has been a huge help for me because a social media service like that gives so many like people a chance of a platform so that they can be their own advocate. So I actually learn a lot of my person first language from people who are experiencing like certain disabilities or discrimination. And I've even learned things about myself because of the way somebody was using their platform. So I think with how connected our generation has become, it's easier to learn about how the language is changing. And it's easier to get it to change faster.
Okay. It's interesting. I've never looked at TikTok. Wrong generation here. Lauren.
Yeah, I kind of agree with what Kat was saying. I also haven't like heard people talking about this really in the medical community. If they are, it's honestly usually something that I bring up. And I feel like it's one of those things that I try to go out of my way to learn things on my own time, in order to be more respectful and be more aware of how to better treat patients and talk about patients. But I think that medical education, at least what I've experienced, is very behind shifting their language, and it takes a long time for it to trickle down. Like, they still use the R word in documentation, and I hate it. Every time I see it, it makes me want to, like, I don't know. But so so I ask people, like, do you use that term to the patient's face? And they're like, oh no. And I'm like, well, then why is it documented? And like, and it's one of those things, like, it's a clinical diagnosis that still exists in those words. So you sometimes have to. And like, that's how far behind we are. Like, people have known that for years and years now, that like, that's not okay to say. I don't even want to say it. But so I try to go out of my way to learn those things, but I haven't really heard people talk about it. I also had a quick question for anyone. It was from Friday. I think it was Alex was his name. I'm really bad at names. But he said that he didn't like the term high functioning. And which I could see why that is not a good term. But I do think it can be sometimes helpful for knowing like the amount of like services or accommodations that someone needs, like the level of support a person needs. So I was wondering if anyone who had more experience working with people with autism had any other terms that could be used instead of high functioning that they've heard. I would be open to hearing them. Sorry if that's kind of off topic. I felt like that kind of.
No, it's not off topic. It's a very good question. And I think, yeah, thoughts on that?
My TikTok advocates want a lot of people to start using support needs. They have more support needs. They have less support needs. That's what I don't have anything in autism, but I have a lot of people I follow on TikTok with autism who use that.
You know, that's interesting. That's a nice way to shift it from being something that's inherent in the person, because the issue with high functioning is that then you're also applying low functioning, right? Emily.
I think Erin might have had her hand up before I did.
Okay, Erin.
Yeah, I've heard people say like high high social support needs or something like that. So kind of getting into the idea that there's a web of different supports that you might need or might want. So I've seen either just like high support needs or high social support needs or high sensory support needs. Sometimes people have more detail.
Mm-hmm. Emily?
I can just second what Julie said in the chat, like using level of support as language instead. And there are like specific levels. So I've been able to sit in on some discussions with parents where the physician is, telling the parent what the overall results of an evaluation would be, and they'll explain what the support needs are in like the different domains. Like they might need more social support or they might need more support in a different area. But I also wanted to say that I definitely agree with Lauren that medical school is not, medicine as a whole is pretty far behind here. I will say that it's not all bad news. There was actually a course that my school held specifically surrounding use of language in medicine, and it focused pretty heavily on disability. So at least there was that. There is something.
Yeah, and one of these resources is from the American Medical Association. That's one of the reasons I posted it. Because I agree with you. Medicine, we're behind in this. Kat, your hand's up again?
Sorry.
Good. That's all right. No, it's good.
I know with audiology, I've had discussions with my peers about how a lot of us have even tried to stop using the term normal to describe a hearing loss, because normal implies that there is an unnormal. So we've even tried to start using the word typical instead when it comes to certain hearing losses, mostly because I had a friend in my class share with me that growing up, she kind of felt like she wasn't normal because of her hearing loss. And that was just something that was highly traumatic for her. So I know a few of us in our cohort have even tried to stop using the word normal in cases other than outside of like within normal limits, but a lot of us have tried to start using typical instead.
Yeah, and I'm seeing Grace's comment about making speech path 2 typical language development rather than normal. Okay, I'm gonna kind of challenge that. I'm making that neurotypical versus abnormal or typical development. Is typical going to take on a new connotation? Are we going to be looking for something other than typical? I mean, will typical become sort of a stand-in for normal? I'm saying this because some of the words that have been used as we've made changes over time, what has been, it changes. Aaron.
Yeah, this is actually something that I've thought about as well. And I think at some point, typical, because it's such a close synonym of normal, might trend to being the new normal that we end up using.
Yeah.
But the argument of neurotypical, neurodivergent, divergent implies that you're diverging from a norm, so you're still in that outcast, that other group. And I did listen to somebody make an argument about how he's not going to call himself neurodivergent or neurotypical. He chose some other words and that got into a whole nother thing, but I think typical might trend to be our new normal, but I'm sure we're going to figure something else out. Yeah. We seem to be very fluid in this area.
Language evolves. Any other comments before we adjourn?
This is Lisa real quick. I had just typed in the chat that, coming from me being a parent with a young adult with Down syndrome, we really aren't too big on our children being compared to typical children. We hear that a lot. So when you're talking about like typical, right? So, I mean, you can't, I think we're all, been living this life with Lily for 18 years, so I'm used to a lot of different things, but I know nobody means harm by it, but there's like so I'll be like, I hate to say the word typical, or I'll be like, okay, as opposed to someone with 46 chromosomes, right? But then like, a lot of people aren't gonna know that either. I mean, so yeah, I think everyone, I would never call anyone out or anything like that. It's like, like typical, right?
So it sort of feels like being compared to normal, it's very
Right.
similar meaning to normal.
Right, like, and there's something wrong with my child who should be
Yeah.
just the way she is with her 47 chromosomes, right?
Yeah. Can you think of language that would be more comfortable, or would you just prefer your daughter not be compared to other children?
Right, I guess that, I mean, but I do it. I could say compared to, and I'm like, because lack of better word, like, and depending on if I was talking to somebody, they're, typical, they would get that, right? If just like not, talking to people that on the phone or families like that, wouldn't really say that. I don't know, probably maybe it's just like the whole comparison, but sometimes it's like if in trying to explain something, comparing her to what somebody who does have 46 chromosomes, with no genetic condition or cognitive impairment, might be like, so I mean, I think people are really understanding of a lot of things. I think it's harder when you're a newer parent. Well, I don't know, maybe, I guess it could go either way. But yeah, I don't know that I don't know what a better word is really. Just someone who is, that's hard. Without a disability, I don't know. Somebody without a disability, but yeah, I mean, a lot of people have hidden disabilities, so.
Yeah, I mean, maybe it comes down to, is it useful to make the comparison at all?
Right, and that I guess would probably be my stance is, why do we have to compare that? Isn't that part of the issue for people with disabilities? They're always being compared to a typical person, to a normal person.
I'm seeing on from Aaron posting. Well, thank you. Jeremy Andrew Davis. Other thoughts? Any thoughts from other faculty on the call? Oh, yes. Raina.
Rana has her hand up.
Yeah, just like what Lisa said about even in school, they compare typical kids to another typical kids on their academics. So they do the report to see where are they in language arts or math. They use comparing everywhere. I mean, the way sometimes when I see my kids report and when they put my kids and they comparing them to other kids in all states, I mean, they always using comparing with everybody, which is, I feel, I don't know. They always there's something to compare with.
Yeah. And and there's, I guess there can be some utility there to say, okay, we need to work harder on these skills because most 13-year-olds can do this. So we expect, but where is it helpful? Where is it useful? Yeah.
I think in my experience, when we had all the assessments done and people were using clinical language and reading reports and using like percentile, 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 below average, below average, below average, it was like, okay, well, we know that already. So, and we can read the report. So, you could just tell, like, let's move on to the next piece. Like I know you need that data in order to get us services, but let's not focus too much on that.
Yeah. Okay. Any other comments, or shall we wrap up? Elijah.
Yes, I just wanted to say, I appreciate everybody sharing their how they use language, because in my field we just started working with language, so it's really important for me to know how to say things without offending people, because that's not my intention at all. So that's just something I'm willing to, I'm just really appreciative of that. And also, I've noticed like my time being in Lynn, since I've been learning different stuff from you guys, I've been like, when people will say certain things about like maybe a person with disability, I'm like, well, no, I'll try to explain to them what like some people don't understand what autism is, and like they have those stereotypes. So I was just able to like share some of the experience that you guys have shared with Lynn and educate people. So it's nice to hear all your thoughts and what you guys learn, and you bring it to Lynn because it helps me educate other people. So it's just a cycle of it's just a cycle of educating people. So I just wanted to say thanks.
You just hit on the essence of LEND, and it's not just Michigan LEND. The essence of LEND is to learn from each other and then to use that to educate other people outside. That's that's why we call it that's the leadership part, and the education, and that this interdisciplinary learning from each other. And I think I can speak for all the faculty that we learn from all of you every year also, very much. I see claps from Janie. Okay, well, you get 12 minutes of your evening back. Oh, just a second, Kat. Labels are important. Yep. Thank you for that. Yep. Can everybody see the chat? That labels are important. If someone trusts you enough to offer how they label themselves, try to remember it, because it feels very trust breaking to hear someone label you incorrectly. Yeah, it is important. It's not trivial, is it? Excellent point. Okay, well, why don't we end the evening on that note of respect. Respect and compassion. Care about people's trust, and they're giving you their trust. All right, Mike, anything you wanted to add?
Nope.
How about the evaluation? What's happening with that?
I don't have one for tonight since we changed the session. So.
Oh, okay.
So you're off the hook. Just
All right.
I sent a reminder about Friday's eval though, so if you haven't done that, please do so. I'll probably close that in the next couple days. So.
Okay, all right. Off the hook for an evaluation tonight. Look, you get 10 minutes back this evening, and you saved the time on evaluation. Good. Somebody said there was a good discussion. I thought that was a very good discussion. Thank you very much. Good discussion.
There's your evaluation, Jane.
There we go. Well, the value you can from the discussion, the good discussion is from you. All right. Okay. Well, good night.
Great.
Bye-bye.
Thanks, everybody. And
bye-bye.
We'll see you in a couple weeks. Module 10 does open up, or is open, so you can start working on that. And there is a team activity for the next Zoom session, which is on the 24th. So thanks again.
Bye-bye.
Thanks, everybody. Bye-bye.